Physical examination, left-sided, everything's pulmonary. Crackles. Step, crackle, pop, step, crackle, pop. Where? On both sides, bilateral. What are you going to find on x-ray? You're going to find pulmonary edema, and you'll find opacity, both sides. Bibasilar crackles, bibasilar opacities, because that's what edema looks like. What is this edema? It's transidate. It's protein poor. Protein poor. Increased hydrostatic pressure, right? Increased hydrostatic pressure, that causes the pulmonary edema, you tell me. Cardiogenic or non-cardiogenic cause of pulmonary edema? Obviously, cardiogenic. Is that clear? Transidate. Increased hydrostatic pressure. Obviously, there is a reason as to why I asked you that question, because later on, we'll talk about non-cardiogenic type of pulmonary edema in pulmonology. And when we do so, then we will refer to what's known as increased capillary permeability. Therefore, that would be exudate and protein-rich. Now, it's transidate. S3 gallop. What does that mean to you? CHF, large left ventricle. Woo! Blood is rushing into left ventricle in a hurry. And you're going to create an S3 where after S2. Come on, bring this stuff together. You got this. It's all you. You have control over your education. Doesn't that feel good? Right-sided heart failure. Positive JVD. Pitting lower edema. What does pitting mean to you? Transidate, transidate, transidate. Protein poor, protein poor. Perhaps ascites and hepatojugular reflux. What does that mean? Touch upon the liver. Upon inspiration, whoop, comes the jugular. Not good. Right-sided heart failure. Ask a question? It's a stupid question, but you can do this. Cor pulmonale? No, that's not what this is. Right-sided heart failure, secondary to. Left-sided heart failure is a particular topic here. Let's just make sure we're clear. At some point, we'll get into cor pulmonale. Then we'll start talking about pulmonary fibrosis, talk about pneumonia, lobar type of consolidation, so on and so forth. At this juncture, not yet. Chest x-ray. Well, here you have a large apex, cardiomegaly. I talked about this a number of times. Now, the curly B lines represents, well, tell me about lymphatics. When it rains on the roads, well, you have the gutter system, which is responsible for removing that excess fluid, right? That's what the lymphatics are. The lymphatics are the gutter system of the roads. The lymphatics are responsible for, in the interstitium, to remove the excess fluid. How can you confirm this? What if your patient had lymphoma? What if your patient had a tropical disease such as elephantiasis secondary to Witt-Chiari-Bancrofty? What is that going to do? Block off the lymph. When you block off the lymph, my goodness, you cannot drain out the fluid. What do we call that? Lymphodema. Right? So my point is this. When you have excess pulmonary edema, obviously lymphatics are quite active. Welcome to curly B lines. The echo, what are you going to find? A systolic ejection fraction that is decreased. Clear? What do you want to do with this patient? Management. Overall, improve quality of life. Increase comfort. How do you do that? Oh, maybe something as simple as recommendation. A couple of pillows. You at all costs, you want to try to reduce the amount of time this patient spends in the hospital. Absolutely. Prolong life. Treat with proven therapies that is going to do what? Decrease mortality. What does that bring us to? Neurohormonal blockade. What kind of drugs are you thinking about? How about spironolactone? How about ARBs? How about ACE? Really? Spironolactone. What is that knocking out? It's an aldosterone receptor antagonist. You're not using it for its potassium-sparing effect or quality. That's great. But really, that's not the point. It's the fact that you're knocking out the aldosterone. What does remodeling mean, by the way? Remodeling is the fact that the heart is trying to regenerate, but the problem is it might then actually introduce fibrosis. And when you do so, through the repair process, you might then actually end up creating more harm than good. And if you're able to slow down or perhaps even inhibit some of that remodeling, then just maybe you might be able to increase the survival time of your patient. Wonderful. You look for those type of drugs. Neurohormonal, and by that, beta blockers, metoprolol. ACE inhibitors, you don't produce aldosterone. You have ARBs, you block your aldosterone. Aldosterone receptor antagonist, welcome to spironolactone. Is that clear? Correct underlying cause? Absolutely. Maybe this congestive heart failure was due to some kind of valvular defect. Aortic stenosis, mitral regurgitation, revascularization if needed. So, for example, if this particular CHF was caused by MI, why not try to go in there and do percutaneous type of intervention, PCI, coronary artery bypass grafting if needed? Treat hypertension, thyroid disease, autoimmune, all of the different causes of heart failure that we have covered in this lecture series. Stop offending medications, maybe calcium channel blockers, and maybe perhaps NSAIDs. Quality of life, sodium, cut it down. Maybe loop diuretic to improve. Get rid of the pulmonary edema. I'm having a hard time breathing, doc. All right, let's get rid of some of that fluid. Maybe you feel a little bit better. Obviously, you're not treating the congestive heart failure. You're treating the symptoms for the patient. What's a symptom? The patient is expressing trouble. What's a sign? You, as a clinician, finding the edema. Think PT in symptom. That's your patient expressing. Sign is you. You are the sign that is then going to find the different clinical manifestations of a disease. Reduce hospitalization. How are you going to go about doing this? Maybe perhaps positive inotropic agent if needed. What does it do? It blocks the sodium potassium ATPase pump on the basolateral membrane. So therefore, where's my sodium? You tell me. You got this. Sodium is accumulating where? Inside my myocardicyte. If it's accumulating within my myocardicyte, it's not being pumped out, and so therefore no sodium is coming in and calcium is not leaving. So indirectly, what are you doing? You increase your intracellular amount of calcium, and that intracellular calcium that you're increasing is then going to perhaps bind to your troponin C, or maybe perhaps even increase the amount of calcium that's being released from your sarcoplasmic reticulum. Do you see as to how everything is being integrated? Do you see as to how, by learning your basics, and you finally get into JOX and digitalis and such, that by increasing calcium, then you might do what? You might be increasing your positive inotropic effect. Fantastic. Now, the part that you want to worry about is, well, there's every possibility AFib kicking in. So that you want to be careful of for a number of reasons. We refer to warfarin as being prophylactic. Now, treatments for neurohormonal. Well, what do you want to do here? You want to try to decrease the afterload. You can do so by giving angiotensin type of inhibitors. And so therefore, the less amount of angiotensin 2, then you have less vasoconstriction, you decrease your afterload. Does that help with cardiac output? Oh, yeah. Does that ACE inhibitor also increases quality of life because it inhibits remodeling? The 5 classes of medication, pay attention, the 5 classes of medication that have been shown to reduce mortality by inhibiting remodeling include ACE inhibitor, pril, beta blocker, metoprolol, nitrates, ARBs, losartan, and we have spironolactone, which is an aldosterone receptor antagonist. The 5 classes, look for these. All depends as to what that question and what your attending is going for. Are you trying to treat the pulmonary edema? Please don't say ACE inhibitor there. You'll be laughed out of your rotation. Pulmonary edema, furosemide. Get rid of your fluid. If you want to improve the quality of life, then you start thinking about these drugs. Is that clear? Yes.